for inviting us, the two co-moderators for the session, and of course, all the esteemed speakers. And I'm very grateful for my colleagues, my former colleagues at Dana-Farber and Brigham, Dr. Bellin and Dr. Burstein, for joining us. I was going to give a little bit of updates on breast cancer surgery, and I think it ties nicely to the previous talk, focusing on neoadjuvant therapy, although I'm not going to discuss much about the axilla, more on the breast side. And when we're discussing neoadjuvant therapy, are we really losing the opportunity for breast conservation, which was one of the reasons why preoperative therapy initially came to be? This is a woman with a large triple negative breast cancer.
Please use the presentation mode.
This is a woman with a large triple negative breast cancer. She underwent preoperative therapy. And then the MRI, the sagittal MR below, shows that the tumor looks like it disappeared. There's a clip artifact where the biopsy site was. So I think that's wonderful from the oncology standpoint, for the patient's hopefully long-term outcome. But as a local therapist, what do? Do we resect just the previous biopsy site? Do we resect the pre-surgical volume of tumor? Somewhere in between? And those questions still actually are not well answered and well defined, although I'll talk a little bit about that today. So we're going to go over patient examination and some of the imaging modalities being discussed in the pre-therapy setting to determine who would be candidates for breast conservation. Who could be considered for breast conservation after preoperative therapy, and who should undergo mastectomy? And could we predict this in the modern era? There'll also be a couple of novel things that I was working on in Boston and now at Yale that I'll show as well. So what we do know in the neoadjuvant setting is that we can downstage the primary tumor, and when we're not giving drugs that are on trial, it provides effective systemic adjuvant therapy. However, some of the things that haven't been well defined is, can we identify biomarkers that could predict long-term outcomes and options for patients? And really, can we sequence the preoperative therapy and assess the tumor dynamically and be able to switch therapies in case they're not responding? And some of that we do see in the I-SPY trial series that have been done, but really hasn't been formalized in a larger setting. In the United States, and I know the data in the Kingdom of Saudi Arabia and the MENA countries are different, there's about 2 to 4% of our patients who present with inflammatory breast cancer. Locally advanced breast cancer is about 10 to 15%. And historically, we either give chemotherapy, endocrine therapy, and or targeted therapy. It reduced the size of the tumor. And historically, it was always followed by mastectomy, meaning that we were taking inoperable breast cancer to make it operable. And now we were taking patients that were candidates for mastectomy originally to attempt breast conservation. The rationale was that there was actually data suggesting potentially a survival benefit in this, but there have been many randomized and non-randomized studies that have shown that survival is equivalent. We've reduced mastectomy rates, no difference in overall survival, disease progression, or distant recurrence. The data on the local regional recurrence was a little bit conflicted, and we'll go over why that was. This is a large meta-analysis of about 4,000 patients from 9 randomized trials published in the JNCI, comparing neoadjuvant to adjuvant therapy, and really showed no difference in death, disease progression, local recurrence. When you look at the data, really without looking at some of the caveats behind it, there was a suggestion that local recurrence was a little bit higher, but that included patients that received radiation and no surgery. And when you actually gave appropriate surgery and radiotherapy, that number was not statistically different. These are older studies, so the response rates are much lower than we see in the modern era. And we'll go over some of the newer data in a little bit. The majority of these patients came from the trials that are well known to this audience here, the EORTC 100902, the NSABP-B18. I think in general, outside of the clinical trial setting, surgery remains essential in management. And although Dr. Bellin may say a little bit different, radiation therapy alone cannot be considered a substitute at this point for most patients in the preoperative setting that have very good responses. And I think some of that is depending on how the tumor responds. Some of them shrink concentrically. Others, for example, like in the HER2 positive and the lobular breast cancers, there are often big holes that are made in the tumor. And I think research really shouldn't move beyond path-CR and breast conservation rate. We should be looking at imaging and molecular markers, try to identify non-responders early to tailor results. And again, I know this is going to be reviewed, but I think it's important to set the stage that trials like NSABP-B18, which is a very elegant yet simply designed trial looking at operable breast cancer stratified by age, tumor size, and nodal status, went on to surgery followed by AC times 4 or Adjuvant Cytoxan, then followed by surgery. Excuse me, there was an increase in, there was a significant clinical response rate. The path-CR rate was about 13%, but we saw a significant increase in breast conservation, also a substantial decrease in the downstaging of the axilla. I think more importantly, overall no difference in disease-free survival and no statistical difference in breast tumor recurrence. So NSABP-B18 did not sit alone. There were trials done at the Royal Marsden and the Institute Curie, all very similar in design, and importantly showing that the breast conservation rates had gone up. There was really no difference in general in most of the trials for disease-free or overall survival, and importantly, no difference in breast tumor recurrence. So the thought was, if 4 cycles of chemotherapy were good, how about additional chemotherapy? So NSABP-B27, updated by Priya Rastogi in Pittsburgh. This trial looked very similarly at operable breast cancer. And the thought was, well, can we either do AC times 4 followed by surgery and then 4 cycles of docetaxel, or do you give it all up front and then go to surgery? And even though we were able to double the path-CR rate, the breast conserving therapy rate did not increase statistically. It was 61 versus 63%. We've also found that both in the United States and in Europe and other parts of the world, that path-CR correlates with event-free survival, and their guidance recognizes that path-CR as a surrogate endpoint, potentially suitable for approval or more rapid approval of newer drug therapies. So this is a typical preoperative treatment plan: multiple cycles of chemotherapy or drug therapy, multiple points of assessment, surgery, radiotherapy, which somehow fell out of the box, and then extended biological therapy, either anti-HER2, anti-ER therapy. How about physical examination? Well, we all, of course, do physical exams. It should be done at time of diagnosis and fixed intervals prior to surgery. I've seen surgeons and oncologists and radiation oncologists use their hands, tape measures, calipers, all forms of size estimation. The challenge with physical therapy is that the correlation coefficient, or how well does our estimate of tumor size to final pathology, is not that great, whether the patient goes straight to local therapy or in the neoadjuvant setting. You can see the correlation coefficient of 0.4 to basically 0.8. 0.5 is basically a coin toss in terms of accuracy. Of course, mammography is the standard of care. There are challenges and difficulties with lobular breast cancer. Again, the correlation coefficient varies widely in the literature, both in the neoadjuvant and those that go upfront to surgery. Ultrasound is very operator dependent and time dependent technique. There are some really excellent correlation results from some of my radiology colleagues in the Asian countries of South Korea, Japan, and Taiwan. There are difficulties with lobular breast cancer. And again, the correlation coefficient ranges from 0.4 to 0.9. This is a woman with a large, and you can see pathologic nodes on mammogram and ultrasound. And then she got the MRI, and the MR is a newer imaging technique with greater sensitivity and moderate specificity for breast cancer. The technique is driven by equipment, interpretation sequence, and suppression software as really required. Dave Sagaro, who was a previous fellow of mine now back in Australia, really showed a much higher correlation of MR to pathology tumor size. This is the same patient with MRI. The MR, you can see, shows enhancement of the tumor, but there's this non-mass-like enhancement anterior to the tumor. And then the question is that DCIS, or is that something more than that? In this case, we had the tumor biopsied and there were clips placed. This was early on in our experience at Dana-Farber and Brigham, where we wanted to bracket the tumor, and that has changed. We usually now put one in the center. And in this case, it was actually rather interesting that you can actually see the clips being pushed out and after preoperative therapy. Maybe this was tumor elastosis or fibrosis that had pushed it out. And early on, we didn't know really what to resect. Do we resect the pre-treatment volume, post-treatment volume? Do I take the clips out or something beyond that? And that was something that we need to continue to work on. This case went on to lumpectomy and it was DCIS with microinvasion and clear margins. But I resected a lot of tumor at that point. And can we do better? This is the Amigo suite at the Brigham and Women's Hospital. This is at the time, the only operating room in the world that had both a PET CT and MR built into it. This sits below 75 Francis Street if you come in. And I ran several clinical trials that are still actually open in the Amigo suite at Brigham and Women's Hospital. And I've opened them at Yale now. So I think this is kind of where I'm discussing something a little bit more novel, is that most women actually all women who get their breast MR get that in the prone position, yet we always operate on them in the supine position. And the question ends up being that, the breast is not a fixed organ, it moves. And I've never operated on a woman's breast in the prone position. And how does the tumor change? So we did an Amigo phase 1 clinical trial looking at use of intraoperative MR and correlating that to ultrasound, mammogram, and physical exam. And it was really a feasibility study. No one in the world at that point had operated on the breast inside the MRI. So we were able to show that it was a safe, sterile procedure and feasible procedure. And actually the operative times were not very different than those that were undergoing breast conservation. My first case took 146 minutes, which for a lumpectomy sentinel node sounds very long, but I was able to drop it down to 91 minutes on average, or mean of 114 minutes. And that actually included 2 breast MRs being performed intraoperatively at the time. So our historical re-excision rates were up to 40%. Amigo dropped it to 16%, and there were no invasive areas. It was just 2 cases of DCIS in our phase 1 trial. And I think the exciting thing was that when you overlay the tumors in the prone and supine position, the upper one is prone, the lower one shows supine, and then you overlay them, you can see so much difference in terms of not only the tumor location, but also, just as importantly, there's tumor deformation when you do this. We do a rigid registration of the MRI using fixed landmarks in the pulmonary venous system. And again, similarly, another patient, when you do the prone to supine MRI and you overlay it, you see such a big difference in them. We're looking at this also in the neoadjuvant setting at Dana-Farber and Brigham, using the prone and supine MR. The green is the preoperative therapy prior to neoadjuvant, and the blue was afterwards, and it wasn't a huge response. When you look at this overall from prone to supine on multiple cases, and you overlay the tumor, you can see that there's quite a bit of difference between the prone to supine imaging. And I'm going to play this one video, just kind of gives you, it's a very short video, just showing you the how we do this. So this is the intra-op MR that we're doing. We, just like we do everywhere else, we do a sentinel node up front. This was one of my first cases with Dr. Claudius Conrad, who's now was at MD Anderson and was our fellow. We do a lumpectomy just like we would in any other operating room, remove the tumor. Then the MR machine comes in, we do an intraoperative MRI. So I temporarily close, fill it in with saline, and then do an intra-op MR at that point. Then I go back and do multiple shave margins to be able to look at that. Let's move on. So what happened after phase 1 Amigo was phase 2. Now we're looking at intraoperative MRI and mass spectrometry, and that work continues with Dr. Tan Barbie. The mass spectrometry work is really elegant work done by Dr. Natalie Auger and myself. We published this at PNAS looking at tumor changes and spatial distributions of various intensities of different lipids. Our neoadjuvant therapy guidelines are baseline mammogram, ultrasound, and MRI, core biopsy clip identification of the tumor site, axillary ultrasound plus or minus FNA core of abnormal nodes and clips. At the completion of therapy, if breast conservation therapy is planned, mammogram, ultrasound, and MRI, I think it's very important to correlate this to pre-neoadjuvant therapy imaging. Surgery, if breast conserving therapy is going to be done, you have to plan that very closely with your imagers in terms of wire placement, seed placement, and then obviously if the patient undergoes mastectomy, reconstruction, and coordinating with our radiation oncology colleagues. So in summary, and before we'll get over to a couple of the preoperative therapy trials in the modern era, we are thinking that preoperative therapy really should be the same types of drug therapy unless you're doing that on clinical trial setting. I really think it's important to do the mammogram, ultrasound, MRI, physical exam, same imaging pre-NST after and post-NST. The axilla was really addressed very elegantly in the previous talk. And I think in the last just a couple of minutes, I wanted to go over two trials that I helped run from the local therapy standpoint. One was CLGB 40601 and 40603 on behalf of Alliance with David Alila. 40601 was a phase 3 trial for HER2 positive breast cancer. 40603 was a phase 2 trial for triple negative breast cancer with the primary endpoint to be in breast path CR. But this is really the first trial ever done where we wanted to document the impact of neoadjuvant therapy on eligibility for breast conservation, having the surgeon discuss and then record whether the patient was eligible or not and what the reasons behind that were, and the correlation to breast conserving therapy eligibility to path CR. 40601 was the HER2 positive trial. This was run by Lisa Carey, presented a while ago at ASCO, looking at trastuzumab, taxotere, and lapatinib in various combinations followed by surgery, then dose and AC, and then 1 year of trastuzumab. 40603 was Bill Sykov's study, triple negative breast cancer with paclitaxel, bevacizumab, carboplatin in combinations, then dose AC, and then surgery. These patients were primarily clinical stage 2, a third were stage 3. They were younger patients in the United States. The average age of breast cancer is 62, 63, and you can see here the median was 49, so much younger than we typically see, and the age correlates with premenopausal status, and most were high-grade disease and ductal phenotype. So we determined breast conserving therapy eligibility before and after neoadjuvant therapy, and if not, the reasons. Definitive surgery was at the discretion of the surgeon and the patient. Taking the combined two trials of nearly 700 patients, about half of our patients were deemed to be eligible for breast conservation prior to neoadjuvant therapy. When they got that, 90% remained eligible. I think just as exciting or important was about the half that wasn't eligible for breast conservation when they got preoperative therapy. 42% became eligible. Once you were eligible, if you underwent breast conservation, which was about 3/4 in the always eligible group and about 2/3 in those that were not eligible that became eligible, it was successful 85 to 90% of the time, really saying how well preoperative therapy works in the modern era. The reasons why it didn't work, they were not candidates, were just like what we would think: tumors too large, or probable poor cosmetic result in the pre-neoadjuvant setting. Post-neoadjuvant therapy, non-candidacy, the tumor too large and probable poor cosmetic numbers became less, while things like multicentric disease really shouldn't change that much. However, I think this points to some other issues that we have. When you looked at the path CR rates for those that underwent breast conservation or not, or were eligible or not, the path CR rates were between 40 and 60%. So there was a significant number of patients who we deemed not eligible for breast conservation, yet at surgery, they had a pathologic complete response, really pointing to some lack of the ability of imaging to correlate with surgical results. Factors predicting breast conserving therapy candidacy, just like we would think. The most important aspect was pre-breast conserving therapy eligibility, yes or no. Of these 700 patients, the summary of the study was that about 2/3 of our patients became eligible for breast conservation after preoperative therapy. A third weren't. If you attempted breast conservation overall, it was successful nearly 90% of the time, yet about 30% of our patients went directly to mastectomy. And this is where I think is one of the most important things I hope I can impart on this talk, was that overall our breast conservation rates were 43%. This is in the modern era when I just showed you earlier NSABP trials where the breast conservation therapy rates, when we did not have nearly as active drugs, was 60 to 68%. So we're doing better in drug therapy, yet our breast conservation therapy rates have dropped in the United States. And this is a little bit different, and there are some similarities between Europe and the United States. Neoadjuvant, which really spanned across Europe, the mastectomy and breast conservation rates after preoperative therapy was very similar. However, Gepard-Sixto, our German and Austrian counterparts of triple negative and HER2 positive breast cancer, their breast conserving therapy rates are much higher. So my last question of all of this was, well, maybe this is a very US-centric thing. And so I became involved and was very fortunate to become in the Brightness trial, which was looking at triple negative breast cancers and PARP therapy. The primary endpoint PathCR was published in Lancet Oncology, and I last year published some of the local therapy results. So the outset was that we have really little data on breast conserving therapy rates and the frequency of contralateral prophylactic mastectomy in North America compared to Europe and Asia, and with the BRCA mutation or just non-carriers. Brightness was phase 3 randomized double-blinded placebo-controlled trial in 18 countries, triple negative breast cancer, clinical stage 2 and 3. And I'm sorry, this doesn't read super well, but looking at veliparib, carboplatin paclitaxel, placebo carbopaclitaxel, or 2 placebos and paclitaxel, doxorubicin, cyclophosphamide, and then going on to surgery. Primary endpoint was PathCR, and as the oncologists in the audience know, that the veliparib, at least in that dose, did not work. But again, I was able to build a surgical trial decision-making in this. So 604 patients underwent NST. We were able to do this a little bit differently than the United States. We looked at eligibility and had germline mutation testing on all of our patients prior. And then I looked at variabilities between North America, Europe, and Asia. Looking at about 600 patients, very similar kind of, I'm trying to show this similarly to the US trials. In this case, about 3/4 were eligible for breast conservation prior to NST. And then 93% remained eligible, and about 70% underwent breast conservation. But you can also see that 24% were not eligible, but about half became eligible after neoadjuvant therapy, and breast conservation was done in about half of those patients. The striking difference, I think, were a couple of things: that breast conservation therapy eligible patients in North America were less likely to choose breast conservation, 55 versus 80%, the 80% being in Europe and Asia. This was regardless of BRCA mutation status. And then in terms of the mastectomies, we can see that it was a much higher rate of contralateral prophylactic mastectomies in the United States compared to Europe and Asia, even in BRCA and non-BRCA status. Very similarly, we have a discordance with PathCR and those that are undergoing breast conservation, and we need to do a better job on that. And really, the conclusions of this study were that in the neoadjuvant setting, that breast conserving therapy eligibility was very high, yet despite this, many women chose to undergo mastectomy. That there is, in the United States, and NA meaning North America, because most of them came from the United States, although there were a few Canadian patients, were much less likely to undergo breast conserving therapy than their counterparts in Europe and Asia were much more likely to undergo contralateral prophylactic mastectomy. And really future research is needed to determine patient and surgeon factors that may influence this, making and understanding why more extensive surgery is done in North America versus other parts of the developed world. I think as an oncology community, we must be cognizant of overtreatment, and really the understanding of the mastectomies in the United States is very layered and complex. Genetics, insurance, MRI, celebrity status all play a role. And with that, I'd like to thank you for the privilege of the podium. Again, inshallah, we get to see each other in person one day, and thank you so much for having me today.